Okay, good afternoon. I'm Ruth and I work as an analyst in the New Zealand's Ministry of Health. I'd like to acknowledge traditional custodians of the land in which we meet today and pay my respects to the elders past and present. Today I'm going to present a project that Dawn, Joyce and I have been working on with our cancer clinicians. First, I'll give you some background about why we did the project and then tell you a little bit about how we approached the project and what we learned along the way. How do I do this? Sorry?
Just one here.
Okay, yep, cool, thank you. Okay, so we embarked on this project for a number of reasons. We had published a lot of provisional standards of service provision in 2013, and we had 12 clinical groups with expertise in the different cancers involved in investing many hours to develop those standards. Some of the standards did include measures, but sometimes it wasn't clear why those measures were important or how they could even be measured. Attempts to measure the standard in each of our 4 regions use different methods, different data sources, and presentation, therefore we couldn't really compare those results across New Zealand, which is what we wanted to do. So we carried out a project to assess the data requirements, and it was determined that we needed 1,300 data items to measure all the standards. So we decided on a different approach, and we chose bowel cancer for this project for 2 reasons. One, because we had a National Bowel Cancer Working Group who were very keen to explore how we could use the national link data to calculate and report the outcomes. And the second reason was that we had a bowel screening project where we had a pilot, and the pilot was being expanded from 1 DHB to our other 19 DHBs in New Zealand. So any of the indicators identified in this project would be adopted for that program, and we would have a baseline to measure improvements as a result of that screening program. The project followed on also from an earlier Atlas of Healthcare Variation study on bowel cancer. And we wanted to, we didn't have any data collection resource, so, and we had limited analytical resource, so we wanted to use that national data. That was really our only feasible option. Okay, this one. Okay, so the purpose of the project was really just to use data to drive service improvement in bowel cancer diagnosis and treatment. We knew we had some data gaps, so it was also a name of the project to identify those areas where we needed to improve our data. Okay, so in terms of the method that we used, we reviewed the approaches to developing quality performance indicators undertaken by other countries. We really liked the quality performance indicator approach from Canada and Scotland. So we adopted various components of their methods. We borrowed some of the descriptions, particularly from the Scottish indicators, and we followed many of the methods from the UK National Bowel Cancer Audit reports. We started with a literature review and had 134 potential indicators, then assembled a group of about 18 people with expertise in bowel cancer for a 1-day workshop, August 2019. And the attendees actually included 3 consumers, experts in Māori health and equity, surgeons, medical oncologists, radiologists, pathologists, and cancer nurse specialists. By the end of that workshop, we had 30 indicators, and then we agreed to have a smaller group who would reduce the number of indicators further and add descriptions, including the rationale and evidence for the value of the indicator and driving quality improvement. We then added the descriptions and details and packaged that together and sent that out to our district health boards, managers and clinicians and professional colleges. We also, at that point, assessed the data gaps and put aside some indicators where we didn't have the national data, and then started the process of extracting data and assessing the value as indicators. The final indicators were circulated to the chief executives again and our cancer networks, who were asked to forward on to all the clinical staff involved. Given our intention to report that national data, we worked on an agreement with our Ministry of Health Data Governance Committee, and this allowed us to share that national linked data at a patient identified level with the DHBs who treated the people identified. in our indicators, and this meant the clinicians could validate and audit those indicator results. So, what have we got? Okay, so by the time we'd been through that process, we had 21 indicators that we wanted to report, but because of that availability of data, we could only actually measure and report 7. The data gaps we identified were T&M group stage, clinically diagnosed cancer, some gaps in terms of pathology, radiology, MDT meetings and clinical trials. In March 2019, we released a public report on our website. The report identified DHBs and their results and included some commentary from the lead clinicians around potential areas for investigating variation between the district health boards. Published a Shiny dashboard in August 2019 to facilitate interaction with the data. And in September this year, we held a forum for the clinicians to come together and share learnings among their peers from audits for the different indicators. So we've learnt quite a lot over the course of the 2 years we've been working on this project. While we were only able to measure 7 indicators, actually that's pretty good, and that gave us a huge amount of scope for investigating and addressing variation. Our reasonably up-to-date cancer registry made this project possible. We were able to report on people who were diagnosed between 2012 and 2016 and their outcomes and treatment that they'd received. Being able to link the data at a national level and share the patient-level data with the appropriate clinicians supported strong engagement. And while it's some of the data, missing data, actually mattered less than we thought it might, because often that data is available in the local patient management system. So once we'd provided that data to them to investigate, they could find that data themselves. While it's easy to assume that some indicators, such as the percentage of people who die within 90 days of surgery, reflect the quality of the surgeon, in reality, we found that it actually reflects the success of the whole diagnosis and treatment pathway and the results of the MDT. Really understanding and addressing variation takes many years, and there's really no quick wins. In terms of outcomes from this project, we now have a baseline for some measures, while others we're still continuing to refine the definitions. We've established 2 national data improvement projects, one on clinical stage and the other on systemic and cancer therapy. We plan to update and publicly report the indicator results every 2 to 3 years. So success in terms of whether the outcomes for people with cancer are improving is yet to be measured. However, success in terms of engagement with clinicians has been strong, which is due to the partnership of strong clinical leadership and robust sort of indicators and data. Trust has grown in the model that supports clinical leadership and that peer support. This is reflected in the fact that working groups for lung and prostate as well are now well underway, and many of our other cancer groups want to use the same process. Thank you.
Any questions?
No.
Sure. Well, when you say you're covering other areas of cancer, will that be collaborated eventually to give an overall view of cancer in New Zealand?
I'm not sure what you mean.
Well, you said you were doing
Lung and prostate?
lung and prostate, but will that expand to other areas and then be
Other areas such as?
breast cancer, head, whatever?
Yeah, so we're actually also doing a slightly different process for NETs, neuroendocrine tumours, and we're talking to the head and neck ones group at the moment, and we'll be having our first meeting on the 25th of October, I think, sort of to start with that kind of longer list. We're also working on we're doing some work with melanoma, so they've started doing some work. And we've had a bit of a chat we've had one meeting with the gynae oncology group. I think, I'm trying to think of anyone else that we've, and I think myeloma we're interested as well. There's lots of other groups. It's really just a matter of capacity and, kind of what we've got time to do. Yeah, but yeah, the intention is to kind of, whoever is available and wants to work on them, that we would support them.
I think there was another question up here. Michael?
Interesting. Michael Pizza, Cancer Institute, New South Wales. I've got a question. Is this an ongoing process that you have, this systematic process to use this data for improvement? And is this based on the development of an app, or an analytics app that is ongoing, or is it labor intensive to have data managers and who are required to analyse this data on an ongoing basis?
Okay, good question. We're only using those national linked data sets. So, I'm just trying to think. So, we are doing some work in the background to set up the infrastructure to support that. So at the moment, those are in kind of different data sets, but we've kind of done some work to sort of make that process of putting all that data together easier. And we can probably do a bit more in that space. In terms of the app part is really just about publishing the data at this stage. So we have got a fairly good process. So we've kind of set it up so we can pull it out of the all the different systems and just run some scripts which will put all that data together and publish it in a shiny application. So the process to do that is relatively easy. The most difficult part is actually validating the right procedure codes and the right, sort of sort of time intervals and kind of those kind of things, and validating sort of that what we're seeing in the national collections actually reflects what happens at the local level. So for some of our indicators like return to surgery, we couldn't use the national data to do that. It just wasn't accurate enough. But for our other ones like the mortality after surgery, we don't think there's any problem with that in terms of the quality of the data.
We've got one more question.
Got three.
Thank you very much for the presentation. What are the next indicators you have in mind?
For bowels? No?
Well, currently you've reported 7 indicators.
Yes.
You have 21, you initially had 21 indicators you'd like to report. Just wondering what are the other pressing or popular indicators you would have in mind?
For bowel, okay. They are actually all available. I put a website link actually down the bottom there, but if you just Google Quality Performance Indicators, Ministry of Health New Zealand, you'll come up with a page. And so we actually published those 21. So there are things like sort of whether people had 10-day MDD, or are presented at an MDM meeting. There's some other pathology ones such as circumferential margins or and a couple other things, whether people have DNA genetic testing, MSI testing. I'm thinking off the top of my head. What other ones? There are some chemotherapy ones as well. Sort of the main reason we didn't do the chemotherapy is because we don't have good T&M stage data, so we couldn't be very specific about that. Clinical trials, radiology, sort of whether people's results were reported in an agreed synoptic format. Was that the answer to your question? Yes, thank you.
Thank you, Ruth. I am super excited to see how things have moved on in the last 7 years since I jumped the ditch. I was working for one of the cancer networks before I came over here, and this work was not even started. So it's fantastic to see how far you've come. So thank you so much.